Buenos días, vamos a seguir con el programa. Vamos a estar durante 2 horas hablando sobre vigilancia activa. La primera presentación la iba a realizar Ander y va a hacer una breve anotación sobre su tema para abreviar y ganar tiempo.
Prácticamente, pues en aras a que acabemos en tiempo, porque ha habido alguien que ha hecho alguna apuesta a ver si acabamos antes de las 4 o las 5, entonces, bueno, vamos a intentar recuperar algo de tiempo. Lo que había preparado yo únicamente era un poco también de filosofía en cuanto a, no a la reunión, pero bueno, las preguntas que nos hacemos siempre, ¿no? Entonces, cuando leí este artículo me pareció interesante, bueno, como lo pasaremos con las diapositivas, pero bueno, sale una... Únicamente había un artículo que era las 3 preguntas que salió en European Neurology el año pasado, y al final las 3 preguntas, ¿cuáles son las que se hacían desde el punto de vista, qué es lo que, primero, qué es lo que cuando hablamos con un paciente y le decimos tienes un cáncer de próstata, qué es lo que piensa, ¿no? Entonces, primero, pues voy a sobrevivir o no, ¿no? Es lo primero que están preocupados por decirnos. Segundo, bueno, parece ser que hoy está claro que la gente sobrevive, sobre todo los primeros años, no hay ningún problema. ¿Qué nos pasa luego? Ya eso es más difícil. Segunda pregunta, ¿el tratamiento que me van a ofrecer es bueno o no? Con todo lo que hemos hablado un poco ayer y lo que vamos a hablar hoy, pues a veces se nos complica, ¿no? ¿Cuál es la mejor opción que le podemos ofrecer a un paciente? Y tercero, que es una cosa que nos preocupa a nosotros también mucho, es, bueno, y después de que me han curado, de que me han tratado o que me han intentado curar, ¿cómo voy a vivir, ¿no? Y cómo voy a vivir realmente, cuál es la calidad de vida que tienen estos pacientes. Entonces es una cosa que a veces nos preocupamos poco porque nos preocupamos desde el punto de vista oncológico, pero resulta que hemos tratado a pacientes que igual no lo necesitaban, con una serie de resultados funcionales que realmente hay que tenerlos en cuenta, ¿no? Entonces yo creo que transmitir un poco estas preguntas, que yo creo que nos las hacemos todos y que también pueden ser incluso objeto de un debate mucho más amplio. Yo creo que lo más importante de todo es intentar, como tenía también ayer en la presentación de Bernardino, que salían datos a nivel nacional, de qué es lo que hacemos y luego también lo que no hacemos, yo creo, que es lo que se está haciendo mucho en Inglaterra, que es preocuparse por lo que les ha pasado años después y qué es cómo es su calidad de vida, ¿no? Si necesitan, si tienen problemas de erección, porque todo el mundo dice que los resultados de erección son fantásticos, pero vemos que no realmente. ¿Cuáles son los problemas de continencia urinaria? ¿Qué es lo que piensan esta gente, ¿no? Y sobre todo un poco abogar por estos temas y la mesa es vuestra.
Rogamos, por tanto, siguiendo las instrucciones del doctor Astovieta, que los oradores se atengan al tiempo asignado y que, por lo tanto, miren sus relojes, por favor. Tenemos 15 minutos. Me parece que es, ¿no, Miguel?
Sí, 15 minutos.
15 minutos para la presentación de cada orador.
Okay, thanks. So, 15 minutes. So my presentation is about clinicopathologic variables and biomarkers in active surveillance. So it's going to be short. There are no tricks, just evidence and looking at the outcomes of long-term series. And I think that there's a good discussion, might be a good discussion about what is indolent and insignificant. I would really love to have the opinion of Dr. Algaba. And then to look at what's the evidence about the clinicopathologic and biomarkers in active surveillance. So first of all, what we are looking at, the objective is to avoid or delay local treatment in men who might have disease, but it's favorable, and we want to keep this patient in the window of curability. So this is the difference with the watchful waiting policy. I think this is the most important slide of my talk, and this is about 2 things. The first one, so in the y-axis, is the progression of cancer, and the second one is the progression in time. So the thing is that, first of all, I think we should know how long this patient is going to live. Because if he's going to live a few years, probably the cancer won't spread or won't progress. If it's a patient who's going to live more, then we have a different situation. The cancer is mostly understood as something which begins microscopic and then goes to be localized, going to give a regional spread and then a metastatic spread. Then we have different pace at which this cancer can progress. So if we think these are 4 types of prostate cancer, we can have 2 types of cancer in which we probably don't want to watch these patients because they are anyway going to be spreading very early. So either we want to treat them at the beginning, if we can find them, or we want to treat them at this level, so before there's a regional spread. So probably tumors C and D are not good for surveillance. Then there are the other 2. And I think most of us agree that the tumor A, you can see in time, it's progressing, but very low, as low pace. It's going to be microscopic for a long, long time. So we can say this is indolent disease. Well, let's see what's the evidence. So this is one of the largest series with longest follow-up from Johns Hopkins. So 1,300 patients with a median follow-up of 5 years, but up to 18 years. Obviously, you know, the insignificant characteristics of the disease were developed by Jonathan Epstein. And so you can see the characteristics of these patients. So 71% had what they called very low-risk disease, so indolent disease. So very strict criteria. They had no palpable disease, PSA density very low, only Gleason 6, no more than 2 cores positive, no more than 50% of each core. This was, again, more than 2 patients out of 3. And then there is the remaining of the population was about low risk, 29%. And you can see that these patients were, I mean, they accepted palpable disease, but low volume. And they said in the publication if they were older, but they didn't specify what older meant. The median age was 66 years old. Now let's look at the results. Sorry, the follow-up was as follows. So these patients were followed with PSA every 6 months. It's impressive to know, but these guys were biopsied every year. So there was guys who got 16 biopsies in their life. And what was the triggers for treatment? The violation of any criteria for inclusion. So any against this was a trigger for treatment. So very, very strict criteria for entry, very, very strict criteria for treatment. What's the outcome? So you can see most of the patients were treated. So 57. That's one of the problems, because when we are going to look at the variables, most of these guys were treated only because of PSA or because of length of course. Where they're really progressing, we don't know. But when we look at you know, what's real outcomes, so the overall survival, so anything leading to mortality, 10 years, 93%, 15 years, 69%. But what's impressive is the cancer-specific survival. So at 15 years, it's 99.9%. So 0.1% was dying. This best explained by this graphic, in which you can see the probability of death, and the blue dotted line is the death for any cause, and the yellow line is the mortality for prostate cancer, so very close to 0. So is this indolent disease? Well, if you look at the results, yes. Now, if we go back to the figure, the first one, you have this tumor. So what's this tumor? I think this tumor, it depends by the patient. So this tumor is going to progress. If we continue, the patient is living longer, probably is going to give regional spread. But still, we can remember active surveillance not only avoiding, but also delaying local treatment. If you can keep the patient on surveillance for a few years, it's still very good for him. So if you can keep these patients so far in surveillance, that's a good outcome. So is this one insignificant disease? So I think the best series about this is the one from Toronto. So up to 1,000 patients, over 900. A follow-up, again, similar, 6.5 years. The patients are different. So there are, most of them, they're low risk. So while on the Jonathan Epstein group, they were only 29%, this time they are most of them, 79%. Same criteria. But importantly, there are 21 which are at intermediate risk. So they have Gleason, secondary Gleason 4, a PSA higher, but if the life expectancy is less than 10 years. Median age was 77.8. What was the follow-up? It was less restrictive. So the series is less restrictive in entry criteria and in following patients. So you can see PSA every 3 months for the first 2 years, and then every 6 months. But importantly, they just have one biopsy at 1 year, and then only every 3-4 years. The triggers for treatment was, again, less restrictive. So up to 2009, PSA doubling time was a trigger to treatment, but then it became just a criteria for having imaging or biopsy. And it had to be histological clinical progression to give treatment to the patient. So another type of patients, another type of cohort, another type of follow-up. What's the result? So it's impressive because these patients are more at risk, but only 27 are treated, so half of the others. What's the survival? So the survival, overall survival at 15 years is 62%. But actually, most of these patients are dying of other causes, because when you look at the cancer-specific survival, at 15 years, it's still 94%. 21% of these patients, so 1 out of 5, were at intermediate risk. This is well explained by this image, in which you can see the blue line is the non-prostatic death for men which are older than 70 years, which is against the gray line, which is the same population but for prostate cancer death. So I think it comments by itself, but it's around 4 or 5 times more likely to die of any causes than for prostate cancer. I think there will be a presentation about younger men, but in this case, you can see also the difference between the yellow line, which is death for any cause, and the red line, which is the death from prostate cancer in men which are younger than 70 years. So huge difference again. So what's the evidence about the clinicopathologic and biomarkers in risk stratification? As always, European Urology, they commissioned a systematic review in order to look at this. There were 2 things. The first one, it was the eligibility, and the second one was the progression. So they found a number of papers, which I don't have the time to sum up, but I just want to summarize the evidence. So there are a number of factors. The first one is the patient factors. The second one, the biopsy results, the biomarkers, the genetics, and I left out the multiparametric MRI because there is another speaker talking about this. So first of all, patient factors. What's the evidence? We talk all about this. Is there an impact of all these factors about active surveillance? Well, according to the series, if you're Afro-American, you're less likely to be kept on surveillance for a long time. So it's a negative prognostic factor. Age, well, there are some series saying yes, some series saying no. Actually, there is no high level of evidence saying it's a risk. Family history and BMI, again, the evidence is not so high in order to tell us we should not keep or offer this patient surveillance. The biopsy results. So obviously, this is yes for all, and this is what we are looking at. So if you have an higher lesion grade at biopsy at the beginning or during your follow-up, you're less likely to be on surveillance for a long time. At the same time, if you have a disease burden which elevated, so this can be measured by the maximum cancer core length, the percentage of cores, so the number of positive cores is the same, but it's done differently by different groups. And again, the results of confirmatory biopsy, it's important. So if you got any of this, you're less likely to be on surveillance for a long time, and you're more likely to have more significant disease. And this is obvious. Now, it's more complicated with biomarkers, and this mostly, as I said before, because the literature is biased. So there were a number of series in which the PSA kinetics and the PSA doubling time was a trigger for treatment. So if you look at we just analyze statistically, it's obviously a negative impact on progression. But the truth is that we don't know if these guys were really progressing. We just know that they were offered treatment. So there is a big bias in this. I think we need the prospective studies and new evidence in which the kinetics is not part of the trigger for intervention. On the other hand, there is good evidence about the PSA density. I think it's a very good biomarker because you can measure your PSA and correct this by the volume. So almost of the studies show that the PSA density is very good. And the other biomarkers also, there are some studies showing it's good, although again, they're not really externally validated. Then the genetics, there are some evidence about all of this, but again, these are early studies in which we can see there is some impact, but we don't really have long-term outcomes about this. So I hope I was in the 15 minutes, but so this is my last slides. I think when you offer active surveillance to a patient, you should consider the patient. So how long he's going to live, and this is the trigger whether he should stay on surveillance. And then what's his disease, what's indolent and insignificant, where we don't really have the parameters because we are not so precise to get the difference. We have some variables which we know are important in looking at which patients are going to progress, which are the race, the disease burden, the grade, and the PSA density. And I think in the future, imaging and biomarkers will help in better risk stratification and monitoring of patients and reduce the arms of active surveillance. Thank you.